नहीं मेरी नहीं नहीं मेरी ठीक है, मेरी ठीक है।
अच्छा हो रही।
Hello. Good evening, ma'am.
Good evening, Aminat. How are you?
Ma'am, yes, we can start within 5 minutes. Abhi only 8 participants.
There are 8 participants, I think so. 5 minutes more we can wait.
Yes, ma'am.
We'll start now. I think we can start now.
Yes, ma'am, you can start.
Yes. So, good evening, everyone, and I welcome you all to the 16th webinar of Academy of Pain Physiatrists on a very important topic, which is fluoroanatomy and interventions for lumbar spine. And to speak on this topic, we have Professor Dr. Shovan Rath. He's MBBS MD, FIPP, and FIAPM. He's Odisha's first international pain physician with at least 15 years of experience behind him. And he's done his FIPP from Netherlands. He's certified in pain and palliative care. He's also Director of PainFree Odisha, that is the state's first pioneering pain management center. He's consultant and pain clinic head, Health Village Bhubaneswar. He's specialist in USD, fluoro-guided, and procedures and PRP, BMAC, and stem cell therapy. So I welcome you, sir, and you may start the seminar.
Thank you for the introduction. I hope I'm audible and it's visible. The screen is
Yes.
visible.
Yes,
Okay.
sir.
Okay. Thank you for the invitation for this. So I'll be covering the basics only. How to look at the fluoroanatomy of the skeleton, and we'll be focusing on the lumbosacral spine. So some part of the sacrum and lumbar spine. Okay. So before going into the procedure in detail, just a second. So this is what the normal anatomy that we normally read in our first year. That is, what is the spine? This is what is the vertebral body. These are transverse processes. This is lamina, and these are the spinous processes. And if we look at from the lateral view, this is what we are going to see: the superior articular process, the inferior articular process. Again, this is spine, vertebral body, and transverse process. These are all that we are going to see in the next few slides, that how to identify them and how to do the fluoro-guided procedures. So normally when we are talking about the fluoroscopy, so this is what is a fluoroscopy, or the C-arm that we normally see. You have a X-ray tube below, and that's emitting the X-rays, and that's the human body. And there is a image intensifier that is receiving that signals. And in a way, you are seeing on a TV monitor, the 3D picture is getting converted to a 2D picture, and you'll be able to see that. So this is what a fluoroscope is, that everybody must have gone through. And normally there are 2 or 3 views we can say. Normally what we follow is that is a AP view, and another is a lateral view, and another is a oblique view. These are the 3 views that normally we see. For that we need an this is how is the position is. Normally all the lumbar spine or the sacral procedures that we do are being done under what we can say is a prone position. So how we visualize the target, because this is how the lumbar spine looks like. So the curvature is like this. So whenever we are focusing on a segment in anywhere in the spine, the rays must be coming parallel to the body. Then only it will be visible as a square. So if you are looking at the L5S1, it should be like this. And if you are looking for the L45, it must be vertical, that is on AP view. Now for L5S1, as I said, there must be a cranial tilt. But if it is for L3, L4, it must be in a caudal tilt. So this is what it looks like when we look at the X-ray image. These are the body, these are the pedicle, and these are the spinous processes. Normally, this is what the basic thing is. And in a lateral view, as I said, this is the body. These are the articular processes. So articular processes are formed by the superior and the inferior articular processes. And these are the pedicles. These are the foramens. We will be coming to that later on. So normally oblique view is the view where we are targeting the Scotty dog, and we'll be seeing what are the structures around the Scotty dog. So whenever we are putting a patient under fluoroscope, the first part is midline, make it proper midline so that the spine will be in the midline. The next is squaring of the vertebra. So how to make the squaring of the vertebra? So that the upper border and the lower border must be in a straight line. It should not be looking like a oval shape. It should be like this. So to make it, we have to tilt the fluoroscope either caudally or cranially according to the position. And if you want to make this more easier, what we can do is to obliterate this lordosis. We can put a pillow under the abdomen so that the spine will be straight. So it becomes very easy for those who are learners and they're starting their procedures. They can do in that way also. Now, this is what is the oblique view of the spine, and you have to imagine this Scotty dog. And this is the most important part in the fluoroscopy whenever you are doing the procedure, because every procedure will be done around this only. So these are the pedicles, and this is the face of the dog. These are the ears are formed by the superior articular process. Now this is the body. These are the hind limbs. These are the forelimbs. So this is what you need to observe. And around this only the nerves coming out. You can see in this picture that these are the pedicle. Below the pedicle at the 6 o'clock position, your nerves will be coming out, the exiting nerve root that will be coming out. And these are the superior articular process and the inferior articular process, which is joining. And this is the pedicle. So this is what we need to see in a oblique view. This is how it will look like when you are seeing it under the X-ray view. So this is what the Scotty dog is. You just imagine this is the Scotty dog. This is the dog. And we'll be doing all the procedures around that only. So what are the structures that we are going to see around this structure? As I said, this is the Scotty dog. Just imagine this dog. This is the face, snout. This is the ear. This is the body, hind limb, forelimb, and this is the neck. So these are the facets. Facets are formed by the superior and the inferior articular processes. The joints, these are the facet joints. So whenever we are going into the intra-articular facet joint injection, this is the point if you want to enter into the facet joint. Median branch block, ideally the median branch curves around the junction of the pedicle and the superior articular process. So this is the target point if you want to enter into, if you want to touch the median branch, if you want to go for a radiofrequency ablation. Now coming to the transforaminal approach or the transforaminal disc, if you want to enter into the disc, then your needle must be just anterior to the superior articular process. This is the position of the disc. So if you want to enter into the disc, keep it in the 50% zone, means it will be on the midline, so that your disc will be easily visible and you can enter into the center of the disc. So just anterior to the superior articular process is the position to enter into the disc. That is a transforaminal route. Selective nerve root block, you have to enter just in a subpedicular approach. That was the position, I can say the earlier one that I showed, that is in the safe triangle. And this is the position if you want to go for your surgical approach also. If you want to go for a endoscopic discectomy also, you can enter through this position. And this is what the position for the just the subpedicular approach or the 6 o'clock position, just below the pedicle. If you are entering, then you can target the exiting nerve root, or you can go for a selective nerve root block. Also, if you want to go for a DRG, dorsal root ganglion radiofrequency ablation also, this is what the position is. Now, some part of the radiation safety part that you must remember, that is LRA, that is time, amount of radiation and equipment positioning. This must be in focus. You must not go for burst frequencies. It must be always in a pulsed mode. You are going for a single shot, then the next shot. So it should not be, it should be in a pulsed mode, never in a burst or a continuous unless until you are doing some kind of sympathetic plexus block, or your needle is inside the artery where you can see in a continuous mode. Otherwise, pulse mode is the best one. Barrier, you must use the shields, lead apron, thyroid shields, eyeglasses if it is available, and the gloves if it is available. And keep a sufficient distance from the fluoroscope, because there is a radial X-ray is emitted. So the maximum distance it is possible. Keep a distance always if you want to remain healthy. Protect the patient as well as the staff and the physician. So you must have limited number of shots before going into the procedure. This is what the radiation field is. So you must be away from the radiation field always. Again, what you can do is you can use collimation. In many fluoroscopes, this collimator is available. That means that will reduce down the area of exposure. This is normally what we see. If we want to reduce the exposure, then these are the collimators that is available. There are nowadays almost like all the best quality fluoroscopes have this collimator. This must be used to reduce again the X-ray exposure. These are the safety equipments that you must use. And Radiation summary, this is a technical part, so we'll not be going into this. Or again, whenever we are using this kind of fluoroscope, so what we are using is iodinated contrast that we normally use, or the IOPAC that normally being used. Hexol, or these are coming in various brands, so that can be used. Before using this kind of fluoroscopy and the dye, you must take a history that if there is any history of allergic reactions to that, and you must be ready with corticosteroids and other safety equipments or rescue equipments with you before going for any kind of contrast injection. This is mandatory in all fields, not only in this, but anywhere if you are using any kind of dye, that can be a dye-induced reaction. So anaphylactic reaction. So you must be cautious whenever using a contrast agent. Now, this was in a jest. Now we'll be coming to the lumbar procedures, how to do the lumbar procedures. As I said, the first thing, whenever a patient is sleeping, this will be one by one. The first part is lumbar sympathetic block. Now, first I want to tell you how to position the fluoroscope. This is what the normal patient is sleeping and you are taking a fluoroscopic image. Now, what happens is, you can see if I'm targeting this bone, suppose you can see the lower border is not squared. You can see this is a little bit squared. This is almost squared because this is almost, if you see L5, 4, 3, 2, 1. So this is almost squared. It is coming parallel. So this is not parallel. So to make it parallel, you have to make it little bit cranial caudal tilt. For this and this L4, 5, you have to make it little bit cranial tilt so that the lower border will be squared. So the first point, number one, is spine must be in the midline. Next, you have to square the vertebra that you are targeting. Now align the end pet of the target vertebral body with the craniocaudal tilt that you want. And as I said, for the upper limb vertebra, move the image intensifier caudally. If for the lower ones, cranially. Now I was targeting this L2. Normally, sympathetic plexus block, whenever we are doing for the lower limb, the target is ideally L2 because almost like L5, 4, 3, all the sympathetic plexus are coming and going through L2 only. So if you are doing at a single level, L2 is the adequate part, where if you are going for a sympathetic block, then all the other lower ones can be covered. We can do individually like L2, L3, L4, it can be done. But if you are going for a single level, then L2 is the best part where we can do it. So just imagine this is what the bone is now. Just the before one, this is what L2 was. The lower border was not squared. Now we make a little bit of tilt. Now see, the lower border is squared one. Now these are the pedicles. These are the spine. This is the body of the vertebra. And these are the facet joints. On both the sides, these are the facet joints. These are the transverse processes. So after doing this, what we are going to do is, as I said, we'll be doing the procedures under oblique view. So make it ipsilateral oblique to the same side where you are standing or where you are going to do the oblique. This is how the oblique view is. Now just try to imagine the Scotty dog. This is the Scotty dog. This is the snout. These are the ears. This is the body. This is the hind limb. This is the body of the dog. And these are the front limbs. So this is what you have to remember whenever you are going for any procedure. So whenever we are going for a lumbar sympathetic block, the first point is you have to make it so much of oblique so that the lateral border of the vertebra and the transverse processes are aligned. You can see these are all almost like on a single line. On that point, you have to enter the needle so that it will be touching the lateral border of the vertebra. Because if you remember where is the position of the lumbar sympathetic plexus, these are almost on the anterolateral aspect of the vertebral body. Almost you can say anterior 1/3 and the posterior 2/3 junction. So to reach at that level, you have to make it oblique so that the needle will be reaching at the anterolateral aspect. Now after reaching at this point, So what we can do is we can make it a lateral tilt, turn this EM to lateral view. Now the needle is advanced anteriorly in contact with the lateral surface of the vertebral body. You have to go and touch the the vertebral body, then you make it lateral. Now, once you see, this is on a lateral view. So your needle is almost touching the vertebral body, and it is also on the anterolateral aspect of, because you have to imagine this. This is a circular one. This is not like a two-dimensional image. This is a three-dimensional image, and the needle is almost touching the anterolateral border. Now, after reaching over there, you have to, how you will be confirming that whether the needle is at this exact position or not. If you are going for a chemical sympatholysis either with alcohol or local anesthetic only, you can put a dye and confirm and give. But if you are going for radiofrequency ablation, then you have to go for a sensory and motor stimulation. Then you have to go. Now, after your needle positioning, this is the AP view. You see, this is what the exact needle position in an AP view. This is almost in an oblique view. This is in a lateral view. Now, once your needle is properly placed, what you can do is you put some amount of dye, and the dye will be spreading along the sympathetic chain. It will be spreading along the anterior posterior, on the upper and the lowerward direction along the sympathetic plexus. This is a proper dye distribution. So after this, almost 2 to 3 ml of dye is sufficient. If you are going for just a diagnostic injection, then you can give your local anesthetic and steroid, like particulate steroids can be placed. If you are going for a neurolytic block or neurolytic sympathectomy, then you have to go for alcohol. Normally 60 to 70% alcohol that is being used for these procedures. And where we are going for sympathetic plexus block, normally if you see any of the sympathetic overactivity or sympathetic CRPS of the lower limb, we can go for this kind of procedures. Now coming to the lumbar selective nerve root block. I had shown you the position of how to square the vertebra and where is the position. Now, if you all remember the lumbar sympathetic nerve root block, the position is subpedicular or 6 o'clock position. So this is the first point. Take an AP view. Just see that the spine is in the midline. Then just choose wherever you want to do the procedure. Suppose L3, 4, 4, 5, 5S1, wherever is your target according to the MRI and the patient condition. Just we have to square the vertebra. Just see, we have squared the L4 vertebra. So that means we are injecting at the L4 transforamen. So after this, again, you will be turning the fluoroscope ipsilaterally so that now imagine this Scotty dog. This is what the dog is. This is the dog. This is the snout. That is the transverse process. These are the superior articular process forming the ear. This is the body formed by the spine. These are the hind limbs. These are the forelimbs. And this is the pedicle. Just below the pedicle, this is what your position for the, if you want to target the exiting nerve root or if you want to do a selective nerve root block. This is for L4 exiting nerve root block. Just we are putting the needle over there. Always remember, whenever you are putting the needle, just remember that the bones are your friends. So always try to touch the bone first, then you slide over it. Many people, what they do is they just bend the needle. That is one way of doing it. Many people may follow, may not follow. That's not a dictum. But if you want to see the direction of the needle for the newcomers, you can just initially bend the needle tip a little bit so that you can steer the needle accordingly. Now, after repositioning, you just see this is the position and this is what you are seeing in a lateral view. In the lateral view, the needle tip is just on the uppermost border of the foramen. You can just make it a little bit more, enter. This is what is seen in a AP view. Now, if you put some amount of dye, you will be seeing that the dye distribution is along the nerve root. This picture is of L5S1, not of the L4-5. Sorry for that, but this is how it will look. The dye will be spreading inside the epidural space. Also, it will be coming out through the exiting nerve root. And again, what are the drugs that we normally use? Normally in my practice, I use that is Xylocart and dilute it almost, because it's a diagnostic as well as therapeutic block. So we don't need much of a local anesthetics. Many people may use lignocaine plain or bupivacaine and again dilute it so that it will be almost 1/4 or 1/5 dilution is sufficient, whatever you are using. Along with that, you can use dipomedrol or that is methylprednisolone. Again, per level, normally 10 to 20 milligram is sufficient. So accordingly, you can go for that. Now, another thing is if dual control diagnostic block with different local anesthetic agent had produced more than 80% or more concordant pain relief, and pain relief is not sustained on steroid injection, pulse radiofrequency ablation can be used later on. But many a times we have seen if the compression is much less, then this injection is diagnostic as well as therapeutic. But for patients where the effect is not long lasting, what we can do is we can go for a dorsal root ganglion radiofrequency ablation, as I was telling, through the pulsed mode only, because constant mode we cannot use, the nerves will be damaged. Next is discography. Now, why do you use a discography? If you are suspecting that there is no radicular pain and it is a single disc, patient is complaining of only disc, only a midline pain that is non-radiating, as well as the pain is aggravated on putting pressure. That means long time standing or sitting will aggravate the pain. It's like a circumcised pain and non-radiating. So if you suspect that, after the test, you can go for a diagnostic lumbar injection. So just to see which disc is painful. Nowadays, discography is used in less often because of the risk of discitis. So normally what we suggest is go for an MRI, and on the clinical ground, we can go for the injections. But this is what that can be practiced like discography. As I said, again, this is what the position is. In a oblique view, this is what you imagine. Now, as I said earlier also, these are the superior articular processes. So just lateral to your needle position will be lateral to the superior articular process and you enter. So this is the disc where you want to enter. So we'll go directly hit the superior articular process and you can glide over it and enter into the disc. But always remember, whenever you are entering into the disc, sterile precautions must always be used. And you can use a double needle technique. Like what I use is use a 18 gauge normal small needle, and through that needle through needle technique, you can enter the second needle or the spinal needle through that, so that you will be avoiding the skin puncture and inadvertent infections later on. Now, this is what in a lateral view, you'll see that it is inside the disc and you can put some amount of dye. This is on an AP view. You see that the disc, it is inside the disc in the midline, and you can put some amount of dye to confirm your needle position, as well as if it is a concordant disc or the disc which is causing pain, then while putting the dye, it will be painful. Ideally, whenever we are doing a discography, we can use just 0.5 to 1 ml of dye, and it should be done one level above and one level below, so that you will be 100% sure that which level is painful. Again, normally earlier days, we were using a pressure, that is a striker machine was coming and manometer was attached through it. So there are different pressure monitors through which we can use the see the exact pressure point. So nowadays, this is rarely being used. And many people use antibiotics intradiscally. I don't use intradiscal against steroid, as well as BMAC or PRP. Many people are using this. In my practice, I personally don't use these drugs or these materials inside the disc because of the risk of inflammation or post-operatively discitis. So next coming the facet. This is a very common complaint. Now, if you're suspecting a patient suffering from lumbar facet pain or facetogenic pain, the most common was patient, whenever you are loading the facet joint, it will be painful. It is always better to put a diagnostic block rather than putting lots of medications. It is very easy in a 5 minutes procedure. You can see again, same midline, just make it the spine in the midline, then square the vertebra. Now this vertebra is squared. This one is also squared. So make it a oblique view. You can again see this is the Scotty dog. And as I said, if you are putting intra-articularly, this is the position. This is the superior articular process. This is the inferior articular process. And this is what the joining. So you can enter into this. But if you are going for a median branch radiofrequency ablation, this is where is the position. So initially you can go for a intra-articular injection. If the patient is having more than 50 to 70% pain relief with the injection, then later on you can go for a median branch radiofrequency ablation. You can see this is the needle position, just tilting it a little bit. And in lateral view, you can see this will not be going ahead of this. These are the facetal pillars, so it will not be crossing and going ahead. Again, you can put some amount of dye like 0.5 ml of dye. But again, as if you are going intra-articularly, the space is very less. So you have to, in a longer run, I just don't use it, because once confirmed, I go for the injections, because there is very less space for putting the injection. And if you are putting a dye after that, you are putting the drugs again, you are overloading that, and there will be facetal rupture. So this is what, again, for the median branch block, as I said, and the nerve is coming like this. So your needle must be parallel to the nerves. So that is why nowadays what we are doing, we have just modified a little bit. We are not putting in an end-on view. Rather, we start little below. We just go there and we are putting the needle like this, so that it will not be an end-on view. So that maximum length of your needle tip will be in touch of the median nerve. So we have a little bit of change in that. So this is almost same, the AP view. And now rami communicans block, again, it's a similar one to that of the sympathetic plexus block. Now where we are using a rami communicans block, if there is a fracture vertebra, normally after doing a vertebroplasty, or if you're not going for a vertebroplasty, it's a discogenic pain, again you can go for the rami communicans block. Moreover, wherever there is a sympathetic involvement, you can do that. Again, the procedure is almost same. You have to make it oblique so much that the actually it should be a little bit more in, so that the needle will be touching the anterolateral aspect. But here you can see the needle will not be going to the terminal one, but rather it will be on the halfway, and we'll be putting the drugs. Before that, we'll be putting the dye, confirm it. Either you can go for a radiofrequency ablation, or you can go for a chemical ablation with alcohol or with a local anesthetic, as you like. According to the choices, you can go for this. So these are almost the basic procedures that we do, and these are very easy once you are habituated to the fluoroanatomy, because just imagining a 3D picture in a 2D image, this is what the difficult part is initially, but it needs a practice of 6 months to 1 year. If you are doing regularly, it's very easy to do. Now coming to few of the sacral procedures, these are not much. Again, number one is a hypogastric plexus block. It is almost similar to the sympathetic plexus block, as we said, but the target is L5S1. The sympathetic plexus block, hypogastric block, we do normally for anywhere the patient is having any kind of cancer, chocolate cyst, any of the lower abdomen, then we can go for this. Just I'm showing you the pictures. This is, just look at the picture. This is almost similar to the sympathetic plexus block that we saw. Needle positioning is same, but we have to do it at L5 level. So a bit of difficulty always exists there. Another thing, another approach is also that there is a transdiscal approach also that we normally do. What we do is we'll put the needle like this. The needle will be coming like this, and the needle tip will be here only. In that case, you have to go for a chemical sympatholysis. But this is the position for a radiofrequency ablation. But if you are going for a chemical sympatholysis, you can enter through the L5S1 disc and come here and put the drugs. This is how the picture is. This is transdiscal. Just see, This is a transdiscal one that I was saying. Needle position is here, and it will be like a half moon circle distribution that will be just around the sympathetic plexus. Next is a caudal epidural. Again, is a very important one. Many a times there is not a single level is involved. Like some patients are coming with a multiple level involvement, like L2, 3, 3, 4, 4, 5, 5S1. All the levels are involved. So you cannot, either you go for the surgical approach. Otherwise, if you want to go for a interventional approach, then we try with a caudal epidural, because almost like 1 to 1.5 ml or 2 ml maximum you can see for each level. So almost 10-15 ml of drug will reach almost the targeted level. But for that, again, caudal epidural can be done under ultrasound also. But what I do normally is putting the needle under ultrasound is okay. But after that, many times we have seen there is a dye distribution which is going into the small vessels, because it's a bony structure, there are a lot of vessels inside. So many a times we have seen after putting the needle that the drugs are going into the vessels. In that case, that will be hazardous complications will be seen. So to avoid that, you can put the needle through ultrasound also. This is very easy. And after that, just put dye and make a confirmation. This is what you can see. This is the epidural space and the needle is inside the epidural space. Now, this is what in a AP view. Now, if you're putting the dye, it will be a Christmas tree appearance as long as it is going in and it is coming out at each level, each sacral level. So it will be a Christmas tree appearance. It's a very typical one that is being seen in caudal epidural. But again, even if this is coming, just aspirate properly before putting any amount of drug you are injecting. Many times for normally these conditions like multiple level involvement, also in cases where there is epidural adhesiolysis is needed, or there is post-surgical cases, in those cases also we can go for this. But in those cases, we use hyaluronidase along with hypertonic saline. 10% normally is not available. So 3% hypertonic saline with steroid combination we use. Also, many a times we put a catheter inside, keep the catheter in for 1 day or 2 days, and we repeat the procedure on the next day or the next day. So 1 to 2 days we keep that. This is a tricky, painful procedure because caudal epidural injection of the steroids or these hypertonic salines are a little bit of painful. Next is sacral nerve root block. These are again very easy. You don't have to do much. Go for an AP view. This is what S1, these are S2. So this is normally visible if you are doing an AP view. Otherwise, maximum times you have to just align this. Just see, these are two circles. These are not two circles. Rather, this is the posterior entry point. This is the anterior exit point. So you have to make them align so that you can enter the needle from the lateral side. Just see, this is what we're putting the needle. And this is the posterior cortex. This is the anterior cortex. And you have to align them in a single line so that a oval structure will be seen and you can put your needle inside. You don't have to go much in because vessels are also inside. Again, you can put some amount of dye and see the dye distribution along the nerve. Again, you can put this is same as the transforaminal one. Next is a SI joint injection or the sacroiliac joint injection. This is one point where you don't have to turn the fluoroscope to your side. There are two conditions where you have to turn the fluoroscope to the opposite side just to see the proper SI joint. Because the joints are like this, these are parallel structures. So to enter into those joints, you have to make them opposite side oblique. So if you want to look at enter into the right side, you have to turn your fluoroscope to the left side. So vice versa. And again, the lowermost point is the synovial point, the synovial joint. So the most favorable entry point is the lowermost point where it is easily entered. Just after squaring of the after making AP view, just turn to the opposite side, and now you can see that there's a clear canal. SI joint is visible. Now you'll be entering at this point. You can feel the pop-up while entering into the joint. Then you put some amount of dye. The dye will be spreading along the joint and you can put your drugs inside. And many a times this is also diagnostic, because whenever it is inflamed, whenever you will be putting the drug, the patient will be like shouting a lot. So because it is painful, the injections are a bit painful if there is inflamed joint. Again, if it is positive, later on we can go for a radiofrequency ablation of the joint also. So from L5 to S1, S2, we can do a 3-point radiofrequency ablation of the lateral branches. This is what, if you can imagine this is the needle. Now, after putting the dye, you can see this is what the dye spread is. So your all total joint will be visible if you are putting the dye. RF sacroiliac joint, as I said, if the diagnostic test is positive and if the patient is suffering from, suppose, ankylosing spondylitis, where there is severe pain and is not responding to injections, frequent injections, then we can go for radiofrequency ablation. So what we normally do is we go for L4, L5 median branch. Along with that, S1, S2 lateral branches can be done. So I'll be showing you that. Just wait. This is the lateral branches are coming like this one. 3 positions. So at 12 o'clock, 2 o'clock, 4 and 6. These are the positions where we can put our needles. So first, again, the radiofrequency ablation, the procedure is almost, as I said, was similar in all portions. Normally, after putting the needle, we go for a sensory stimulation, then a motor stimulation. If the motor is negative, then we go for radiofrequency ablation, particularly for this kind of median branch, or these are basically the dorsal roots that we normally use. And almost 80 to 90 degrees for almost 1.5 minutes is sufficient. You may go for 1 to 2 cycles, that is sufficient at 3 levels. So this is what covers our sacroiliac joint radiofrequency ablation. Okay, almost I have tried to cover up everything, starting from your lumbar as well as the sacral component. So anybody having any doubt, we can take up the questions. One thing I want to say that we are having a regular courses for this. For every 3 months, we are doing one classes almost for 3 days, where we will be doing almost 30 cases live that we do. And those who are practicing pain or practicing fluoroscopy guided as well as your ultrasound guided procedures, they can come and see, because it is rare to see 30 cases. Almost we are trying all kinds of fluoro as well as ultrasound guided procedures that a normal basic person wants to cover. So almost Dr. Devasis is associated with me also in those courses. So if people can contact him also if you want. Thank you.
So as yet, I don't see any questions, but I do have one thing. If you can elaborate that before taking up the patient in for any fluoro-guided procedure in the OT,
Okay.
what are the standard precautions we should take, like IV cannula, and what are the things that we should do
Okay.
on the patient before we even start the procedure?
Okay, this is almost normal for any of the procedures that we do under local anesthesia. First thing is you have to evaluate the patient and get to a diagnosis. What is your diagnosis? Number 1. Number 2 is there should not be any infective focus, that you have to confirm. A CBC is a must for all the procedures. I'm telling you what normally I follow. Normal CBC, RFT, LFT, or minimum RFT and PT-INR. This must be normal. You must ask every patient whether they are on any kind of anticoagulants, whether they have recently undergone any procedure or what. That must be in your mind, because if any patient is on anticoagulant, you cannot do any of these procedures. Anticoagulant must be stopped for 5 days at least, and you do a repeat PT-INR. If it is normal, then you can go in. So this is number 1. Search for the infective focus. Patient is having any kind of fever history or any kind of any other history which can suggest that the patient is suffering from any kind of infection. This is number one. There should not be any local infection over the area where you are going to do the procedures. So you must inspect the area before going for the procedure. It is not like that you just did an examination and taking the patient inside the OT and you are seeing there is a big patch of some infection or some skin infection. That should not be there. So local anesthesia, before going for putting any kind of local anesthesia, you must go for a skin test. And you must be thoroughly, either you should be able to resuscitate or there must be somebody to resuscitate, or resuscitation equipments must be there whenever you are putting local anesthesia anywhere, because we have seen such complications happening. It may be 1 in 1 lakh or 1 in 10 lakhs, but if that happens, that is like horrible. Then you take the patient inside the OT, and those patients who are, suppose somebody is diabetic, somebody is hypertensive, they should not stop their medicines. They should be on, the medicine should be on. And next thing is, there is no specific contraindication unless until there is some bleeding disorder or something. If the patient is some sort of taking some drugs or is on any kind of, as I said, anticoagulant, that must be stopped. Otherwise, there is no specific contraindication. And after doing a local anesthesia test, you can take the patient inside the OT. Take a proper measurement of blood pressure and pulse oximeter. Every time I don't put a cannula for each of the patient, because these are very small procedures and we don't need to put a cannula. But if the patient is very thin and frail patient, or is a very old aged patient where you can anticipate some sort of complication, it is better to be on safer side and putting a cannula. Otherwise, it is not required, because hardly it takes 10 minutes for any kind of procedure. And post-procedural advice for the physiotherapy as well as ice pack, you must advise the patient that part. And as you are putting some amount of local anesthesia, you must always ask the patient to be associated with some caregiver, some friend, some family members must be there. It is not that the patient is coming directly himself or herself, because he may not walk after the procedure. He may not ride the bike after the procedure, or may not ride the car after the procedure. So there must be some accompanied person with the patient. And every time, whenever you are going for any kind of these procedures, you must take a proper consent. And there is a consent format for each and every patient. And we do that for every patient. It is not like for any fluoro or ultrasound guided. It is same for everything. And these precautions, what I told, is again same for all the patients. It is nothing extra for fluoro. In fluoro, just you have to be more cautious, because you have to use your lead aprons and everything. You must be away from the X-rays so that exposure will be less. That is what it is. And if you're using the dye, you must be sure that the patient is not allergic to that kind of dye. That is one part. This is one, what in a nutshell, actually, what we follow. And
So one question, you test for local anesthetic and dye both before you take up the
no,
procedure?
we don't. You take any kind of skin test for the dye. That is what we ask the patient, if the patient is allergic to some kind of dye, because many a times what happens, the patient has already taken some kind of injections and there was some reaction, because you can't test that. For the local anesthesia, you can just test in the OPD itself, just through a skin test you can see.
So any allergic reactions you've seen to the dye? What is the most common allergic reaction to dye you have seen in your practice? Any?
I haven't seen actually, but we have heard that the patient will go into hypotension and bradycardia. That may happen. That is why I said, and allergic, there will be skin rashes may be present. If somebody is going into anaphylactic reactions, anything can happen. But that is very rare actually. That is why what we say is, whenever you are doing some such kind of procedures, your dye is the first thing which gets contaminated.
Right.
That is why whenever using a dye for multiple sessions, it must be properly kept, and you should not put multiple injections into that so that it is contaminated, because that's the first thing which is contaminated. And if you are using it in inside the disc again, the disc will be infected also. So that is what it is.
So there are questions like Dr. Abhinav Singh wants to ask that if the needle is inside the blood vessel, what precautions should one take?
Nothing. If the needle is inside the vessel, just reposition your needle and put the drug. Before putting the drug, always aspirate. And it is not that single time you have aspirated and after that you put the whole of the 10 ml of drug or 5 ml of drug at a time. It should be in the aliquots always, like 1 ml aspirate, 1 ml aspirate, 1 ml aspirate, because many a times your needle gets displaced by your hand also, by the patient's position also. Many a times that happens to us. First shot, you'll see that the dye is outside, but the next shot again the blood is coming. And always the blood will come through the needle only when if it is in a larger vessel. In the tiny vessels, nothing will come. That is why I said always, if you are using fluoroscopy, use dye to confirm it. If you are inside a vessel, reposition your needle and then you can give your dye and the drugs also.
Then, sir, there's another question. What is the standard protocol should be followed for patients on antiplatelets, anticoagulants? How many days the drug should be holded, and who all need PT-INR to be checked? I think you
Normally, it is 3 to 5 days. 5 days is adequate for the patients who are on anticoagulants. And after 5 days, you have to repeat the PT-INR. If it is normal, you can go for the procedure. But again, if the patient has undergone any kind of cardiac related surgeries or anything related to that within the next previous 6 months, you must avoid the procedure, because within 6 months, it is not advisable to stop the anticoagulants. So if it is within 6 months, try to make the patient comfortable with the drugs only and try them to wait for some time, because this is not such an emergency where you can stop the anticoagulants. So beyond 6 months, you can wait for 5 days and you can continue.
And there's another question that for viscogenic pain, what procedure do you perform, like steroids, ozone, or PR?
Earlier I was using a lot of time ozone, but now what I've seen is ozone is not that much helpful if there is a protruded disc. So in those cases, what normally we use is, I'm not using anything intradiscally. As I said in my lecture also, I'm not doing anything intradiscally. Many people are using intradiscal steroids, intradiscal antibiotics, intradiscal PRP, BMAC. Many people are using. I don't know, but I'm not in favor of that. Rather, I'll be going for Ramay communicants block along with the transforaminal. That is a safer one. You don't have any complications to happen. And initial days, I'll be advising that those who are practicing, starting their practice, they should not touch the disc at all, because the discitis is the most horrible complication that anyone can face.
So there are a lot of queries regarding your workshops. So I think Dr.
They can directly be in touch with Devasis. Actually, Dr. Devasis is associated with me for those procedures, so they can be in touch with them.
Right. Sir, and like one more question before we close. Like after you've done the procedure, how long do you want, will you monitor the patient?
Normally half an hour to 1 hour for this kind of procedures, because the patient will feel the numbness and may not be able to walk.
Right.
A little bit of higher amount of local anesthetic is there, so that may not be possible. So we tell the patient to wait for half an hour to 1 hour. If after that the patient is comfortable, they can go. But until if I'm getting some kind of complications, we may have to make the patient stay for overnight or so.
So last question, like what is your choice of local anesthetic for spinal, so these procedures like bupivacaine or?
Xylocard, always those who are practicing any kind of pain, I'll be advising use Xylocard.
So for
Xylocard
transforaminal
is everywhere. Preservative free Xylocan. That is preservative free. So the complication rate, even if it is not mixed with, even if it is intravascular, nothing will happen. Because intravascular lidocaine, preservative free, the complications are nil. But if it is preservative one, then cardiac arrest may occur also. But again, if you are using a particulate steroid, that may not help you much, because particulate steroids, if they are going intravascularly, again, complications will be there. But in a way, it is safer, cardiac and renally safe if you are using Xylocard.
So just to reaffirm, so you prefer Xylocard as compared to bupivacaine or ropivacaine for these procedures?
Yeah.
Thank you, sir. That answers the questions.
Excuse me, can I ask one question?
Sure.
Yeah.
Actually, very good presentation, sir. Actually, it is a very short notice you have given for this presentation. So just from the next time, you just give us little prior
Sure, sure.
Because presentation is such a good, we should not miss it.
Right,
Actually,
right.
yes. One more thing I want to ask, ki, how to count the level? One thing,
Okay.
and how to count the level, which level we have to do the procedure. For example, transforaminal, for example, from below we have to count the level, or from above, from T12 we have to count the level. That is one. And second thing, which I mean is exiting nerve we have to target, or traversing nerve root we have to address.
Okay, the first question is the level. And the best part is if you come from above downwards, then it is always better because your ribs will be ending at D12. After that, it is L1, L2, L3, L4, L5. Many a time you may be seeing sacralization of the lumbar vertebra or lumbarization of the sacral vertebra. So you may be confused if you are going from below upwards. So it is always better for the beginners to come from above downwards. L1, L2, L3, L4, L5. So it is the easiest one. Number one. Then number two, and how to see that? Just wherever the ribs are ending, below that is L1. So that is the easiest one to remember. Next is traversing or the exiting route. That you have to confirm from the patient symptoms as well as the MRI. From the MRI, suppose I am seeing it is a far lateral disc, which is compromising the exiting route only, not the traversing one. Then your choice will be different. Now, if you are seeing that it is in the axilla, means your the extruded disc is in the axilla and it is compressing both the exiting route as well as the traversing route, your target should be different. Because what we do, even if we are putting the drug at the 6 o'clock position or just below the pedicle, you must see the dye distribution. If you want only the exiting route, then it is better if you turn the bevel, the dye will be coming out only. Otherwise, we see that the dye must go into the epidural space so that it will be covering the traversing route also. Because you must be seeing this, it is like this. This one is the traversing route and this is the exiting route. So we are putting the drug over here at the axilla. So it will go in to the epidural space, come here, as well as it will be coming in the exiting route. That part you have to confirm seeing the patient, the clinical examination, as well as the MRI. That will only confirm. Accordingly, you will be changing the position of the needle or the drugs. Again, if you go through a live patient, you can easily see that how we do, whether we need a L4, L5, which level we are targeting.
Thank you, sir.
I see one more question in the chat. What are your views about Gasserian ganglion rhizolysis by anhydrous glycerol? As the guy doesn't have a RF machine. So that's
that was almost, I can say that 15 years back, I was using glycerol because those days are gone almost. Because you can use phenol, that is better almost. But again, in my setup, I don't have, neither I have glycerol, neither I have phenol. So you can use that if you don't have a radiofrequency ablation. But nowadays, what happens is radiofrequency ablation machine is available on rent also. You can ask those guys, they can provide you the machine and the results are much better. We have seen all kinds of cases. If you are going for a chemical rhizolysis, then the results will be like 6 months, 1 year on a maximum side. But if you are going a radiofrequency ablation, also these days I am doing balloon compression also, percutaneous balloon nucleoplasty. In those cases, again, the results are much better than radiofrequency ablation. But again, you have to be thorough enough to do those procedures if it is available. In my view, radiofrequency is the best and you can do that. Again, if you don't have, you can go for the peripheral branches neurolysis like maxillary, mandibular, and supraorbital. So these peripheral branches you can do with the alcohol. But again, I'll not be advising for glycerol or anything because since 2010, I have not used.
Okay. So another question, explain about alcohol storage. Like, are you using?
Normally, you can store it in the fridge also. No need of any refrigeration. Normal temperature is enough inside the OT.
And then another question, like are you using 500 ml bottle of alcohols or vials or ampules or a big bottles? And how long?
This is available almost everywhere. You can find it in Amazon also. So 500 ml bottles are available. So you can use it till you finish it. There's nothing like that.
And another question, use of ropivacaine preferred or not when compared to Zydocard?
Xylocard is safer to ropivacaine as well as bupivacaine. So you can use even bupivacaine also can be used. Ropivacaine can also be used. My personal preference was Xylocard because it is preservative free. These days, preservative free Ropine also is coming.
Yes.
Bupivacaine is also coming. So those things can be used. It is all about personal preference, nothing else. Ropivacaine is safer again as compared to bupivacaine.
So it's longer acting also ropivacaine as compared
we don't need longer acting anesthetist because these are the daycare procedures. We are not giving anesthesia. So there is no question of these shorter lasting are the best because patient will come back to the normal work as soon as possible.
Right. Sir, any guidelines regarding taking the dose of steroid, like by looking at the glucose level of the patient before the procedure?
Usually does whatever the drugs we are putting, this is very less chance that it will be going systemically. So the drugs will be deposited normally around the structure, you can say, even if you are using any kind of transforaminal route or intra-articular route. So less likely they will be affecting your sugar level. But it is always better if the patient is having a normal glucose level. It is not like 350, 400 somebody is having. So it is not wise enough. In pre-operative preparation that you have to see, the patient must be, as I said, it should be a normal patient without any, the blood pressure should not be raised, the blood sugar should not be raised, everything should be normal.
So till what level of glucose would you inject? Like we normally take below 200 or
below 200.
Yeah, 150, 180 we do inject like.
Yeah, can be done.
That's okay. Fine.
Hypertensive is it okay, but it should be a normotensive only.
Normally it should be whenever you are doing any procedure, patient should be normotensive, means patient is on drugs, it is fine. But the blood pressure should not be like 180, 190 systolic, it should not happen. Because something happens on table, the patient will blame that it is because of the injection this thing happened. Suppose the patient goes into any kind of complication. So it is always safe to have a normal patient as long as possible.
Can you put this presentation in the group?
Yes, sir.
Sorry?
So we normally have the presentation will be shared. It is on the app group, Academy of Pain Physiatrists group. We normally put it. And if you're a member, sir, I think it will be shared on the website. Normally we have all of those. And another one is they want more frequent webinars on case discussions. So we can work on that definitely.
Yes, ma'am, please.
I think, thank you, sir. That was very well presented and we learned a lot from it. And thank you very much, sir.
Thank you. Thank you. Thank you for the invitation.
Thank you once again, sir.
Thank you.
Hello. Hi, Minaj.
Hi, ma'am. बढ़िया हो गया?
But it was very good. That
Hmm.
presented very well. A recording stop करो पहले.